Hi, everybody. Thanks for joining us tonight. My name is John Schmid, and I am with Cook and Schmid, and we are a firm that helps San Diego County with public outreach. And we're going to have a presentation tonight on the East Region Crisis Stabilization Unit and Recovery Bridge Center. And we will be outlining the services offered there and who will be served, and some of the details about the construction timeline, things like that. And then we will open it up to questions. This meeting is being recorded, and we ask that when you have questions, if you can please put them in the chat, then we will give the questions to our panelists to answer. There's Spanish language translation, and there's also Arabic translation. And on your menu bar, there should be buttons for those translators. If you don't see that, you can click on the 3 dots, and then there should be a translation option there where you can pick English, Spanish, or Arabic. And we also have an ASL interpreter as well, who's going to be spotlighted, so she will always be up in the video. We have speakers tonight that include County Supervisor Joel Anderson. He couldn't make it in person, but he's provided some recorded remarks that we'll play in a moment. We have Dr. Luke Bergman, who's the Director of San Diego County Behavioral Health Services, and he'll be talking about the types of services offered at the CSU, we call it short for Crisis Stabilization Unit, and the RBC, Recovery Bridge Center. And Rachel Solov is the Chief Deputy District Attorney with the San Diego County District Attorney's Office, and she will be talking about how this facility will benefit the community. And then we have Dave Dobson, Project Manager with the County of San Diego's Department of General Services. And Dave is the project manager for the construction, so he will be talking about the facility itself, timeline for construction, and that sort of information. If you want additional information, you can send an email to sdcounty.ca.gov. And we also have a website that's available with details and information, and you can get to that website by scanning that QR code. So now we're going to play the video from Joel Anderson. Okay, you're on.
Welcome, I'm Supervisor Joel Anderson, and thank you for joining us tonight to learn more about the Eastern Regional Crisis Stabilization Unit. There are 6 highly successful CSUs operating throughout San Diego County, and this will be the first one in East County. I want to thank Dr. Bergman and all the county staff for taking the time to explain and answer community questions about these services. Before I leave, thank you again for participating. It's important to me to make government work for you. So with that, staff, if you wouldn't mind starting the presentation, I'm very excited for you to learn about this terrific project. Thank you.
Okay, thank you, Supervisor Anderson. And now I will turn it over to Luke Bergman to talk about the advancing behavioral health.
Thanks so much. I just want to confirm that I'm audible. You can hear me?
Yes,
Yeah.
I can hear you.
Okay, super. So really appreciate that that introduction from Supervisor Anderson. I think there are lessons in brevity from him that I should probably take. I'll try to take for this presentation. I want to note at the outset that I'll be kind of tag teaming in talking through this with Rachel Soloff, who was mentioned as a co-presenter from the District Attorney's Office, and that reflects the fact that this work really stands at the nexus of public health and public safety, and I think it reflects some of the best spirit of work that comes out of San Diego County that really reflects kind of how there is sort of harmony in not just in the goals of people working in public safety and people working on the health side of things, but also often there's harmony in how we think it's best to get there, and this is absolutely such a case. So we've got some slides, and again, Rachel and I will kind of go back and forth, and we appreciate in advance your forgiveness for kind of any talking over one another that we do. This first slide, if folks are able to see it, is one that we in Behavioral Health Services often show at the beginning of presentations on our work, and it really represents kind of at the highest level what we're trying to accomplish across the whole continuum of behavioral health care with our work. And that is to really shift from an orientation that resolves very much around crisis, and that's really anchored to the notion of crisis and crises, to a system that's much more defined by continuous care, seamlessness in care, a reduction in crises and episodes of crisis among people with behavioral health conditions, and also an emphasis on upstream preventive care. I think everybody who is in the county and an observer of kind of what's been happening in the world of behavioral health would probably agree that most of the talk that happens now is talk about crisis and how we intervene in crises, and we're really working to sort of shift that model and shift that orientation. And this work is, we think, pretty dramatically accelerated through investments in what we're talking about today: crisis stabilization units, and also and in particular the pairing with services that are part of the Recovery Bridge Center that we'll be talking about. Because what these services do is they kind of change the patterns of service utilization that we see among people. They're really effective at addressing people who are in moments of crisis and then connecting them to ongoing care so that we don't see them cycling back through episodes of crisis. That's really what these services are designed around. Not just stopgap band-aids meant to address, kind of a fleeting moment with the expectation of that fleeting moment repeating, but really an effort to change the directions that people are heading in their recoveries towards better outcomes over the long haul. Can we go to the next slide? So Supervisor Anderson mentioned that we have a number of crisis stabilization units already, and that this is going to be the most recent, and that it will be the first that's really situated in the east region of the county. And so this map shows the distribution of crisis stabilization units across the region that we have achieved. This has been a very, very active body of work for us. We've made enormous investments in this category of service in the last number of years, and we've started already to see really positive outcomes with respect to the amount of work that these services are doing, and some of the impacts that they're having. So we're really happy to be able to talk about some of those with you all today, and to begin imagining how those kinds of outcomes can be achieved in this most recent version of the CSU and RBC that we aim to establish here. I would note also, and this is kind of reflected in this map, that that really foundational to our approach to this work is this idea that's captured in this phrase, regional distribution. There's been sort of a historical tendency to, to aggregate behavioral health services, right? They're kind of traditionally siloed from the rest of healthcare. And there's been a tendency to sort of build them big and build them separate, and in some kind of usually sort of marginalized space. And we've tried really to sort of lean into that tendency and to push the continuum in San Diego County in a very different direction. And that is a direction toward greater regional distribution and greater community integration in particular, because we know that services need to be close to where people live in order to be effective. We are designing, in other words, these crisis stabilization unit services and crisis and diversionary services generally to serve the communities in which they are situated, so that they are most accessible and so that it's easiest to connect people after episodes of crisis to really meaningful ongoing care that is threaded with their families and with their social networks. I want to, and Rachel, I apologize for this, because Rachel and I didn't practice this beforehand, but we have that kind of relationship. We, just kind of dive into stuff. Is there anything that you would want to add, Rachel, from the public safety perspective to this idea of, or with respect to this idea of regional distribution?
Yeah, for sure, Luke. And I'm always fine with you just leading the way on stuff like this, because to sort of build on what Luke was talking about, is it's sort of a unique partnership and a unique relationship that we have here between the DA's office, behavioral health services. And I don't think you see that across the country. I think it is fairly unique, but I think it's very important because back in about 2018, we really started taking a deep dive into this intersection of mental health and mental illness and the criminal justice system, and looking at ways that things could be done better, recognizing that it was going to take the help of behavioral health services, the partnership, that it really was sort of combining lanes, if you will, instead of operating in silos, on how we can better keep people that are in crisis out of crisis and out of the criminal justice system. When we started looking at it, what we found and what we heard was that there really was not community accessible crisis care that was available 24 hours a day, 7 days a week. And so we heard that from the community, that they didn't really have a place to walk in with their family members that wasn't an emergency department. And what we heard from law enforcement was that they had limited options as well, that if they were interacting with someone in crisis, they could take that person to jail, they could take that person to the emergency room or to the county psychiatric hospital, which may not be conveniently located across the county. If they're up in Fallbrook or out in in the East County, it's not always that easy of a order to take someone to the county psych hospital. And then what we heard from law enforcement is when they were at the emergency departments, it was taking a long period of time because, and this is no surprise, but in emergency departments, if they're dealing with traumatic injuries and life-threatening situations, those need to take the priority. So the really, I think, great benefit, and it's a win-win solution with these community-based crisis stabilization centers, is that it provides that walk-in ability for community members to access that behavioral health care, but it also provides an opportunity for law enforcement, another option for them to take someone that doesn't need to go to jail, that doesn't need to go to the emergency department, where they can take them to get this care, this crisis care, and then they can get back onto their beats, doing the job that law enforcement should be doing. So we've seen the times down to about 15 minutes, I think it is, that the officer can get this individual who is in crisis out of law enforcement hands and into behavioral health care hands. And that's really what is so exciting about this.
I really appreciate that, Rachel. And it's, you know, there is a facet of the kind of regional distribution of things that's also just procedurally really important from the law enforcement or public safety angle. And that of course has to do with the fact that we've got lots of different law enforcement agencies that are working across the county, and a lot of like very separate infrastructure that supports their work. You know, separate access to training, distinct 911 dispatch, et cetera, et cetera. And so taking this regional and kind of region-specific approach also really kind of helps us work more closely with the most relevant law enforcement agencies. And so in the case of the East Region CSU, we've already been in a lot of contact with El Cajon PD leadership and staff, and there's a lot of enthusiasm, I would say. You hear that kind of reflected in how Rachel talks about it, I'm hoping, and how you hear me talking about it. But it's also very true of you know, of law enforcement leadership, that this is seen again not just as a way of, you know, kind of handling stuff in the moment, but it really, I think, you know, promises like improvements to community public health and public safety outcomes over time. So let's sort of get into some additional, you know, sort of operational details and specifics. Next slide, please. This slide, before we do what I just suggested we would do, outlines some of why it is that it's important for us to be focusing on this region. And I think, you know, for people who are joining this call, I'm imagining I see some of your names and know that that you're of course familiar with, you know, with East County dynamics, and the broader public isn't, I would say, necessarily. It can be you know, sometimes a bit surprising when we sort of just talk, you know, out to the county in general about particular importance of addressing the needs that we think the CSU and RBC in particular will be addressing in El Cajon. But El Cajon, the city of El Cajon and surrounding areas actually are places with very high Medi-Cal density. So a lot of folks who are on public insurance live in this region, and we see in indices such as the Healthy Places Index, which was incredibly important to like the governance of distribution of resources through the COVID pandemic, for example. We see on those kinds of indices also that this is an area where there's clear demand for, you know, for additional resources such as this. So now next slide, thanks. Okay, great. So what is a crisis stabilization unit? It is, and some of this Rachel started to frame out. I find like just the most commonsensical way of thinking about it, though this doesn't like capture it perfectly, and there are a lot of people I'm seeing, folks such as Luana Murphy, who can talk in very, very deeply informed ways about this. So in addition, of course, to Dr. Piedad Garcia from our team, who's really been in this space. So lots of deep nuance here, but an easy sort of shorthand is that crisis stabilization units can be thought of as alternatives to emergency departments, where we see a need to provide pretty intensive services to somebody in who is kind of having relatively acute behavioral health symptoms. So where we see needs for care and intervention that go beyond what would be accessible just like through scheduling a next appointment for outpatient care. Right? These are cases where we can't just wait for the next appointment. It doesn't make sense to call your primary doctor and, you know, like do a consult. You need something more than that. These may be cases where in fact services are made accessible through a 5150 or through an involuntary hold, where it is determined that somebody is potentially gravely disabled, may be a harm to themselves, that sort of thing. These are settings that are appropriate for that kind of care, that level of care. There are, among those that were on the map, and this is very relevant also to points Rachel was making, there are two different categories of crisis stabilization units that we're building in the county. Some are affiliated with and even sited within or immediately adjacent to hospitals or mainstream healthcare. And some are situated in community settings. And really like fully integrated into kind of just very like pedestrian retail or reminiscent of retail spaces in communities. And those two different categories of service operate a little bit differently. And so important to note, what we're talking about in East County is a community-based crisis stabilization unit, not one that is connected immediately to a hospital, but a community-based crisis stabilization unit. And one of the dynamics of those, as Rachel highlighted, is that they're particularly accessible to law enforcement in cases usually where there's a 5150 need of care. But these services are also accessible for and widely used by folks who are walk-in. So people being transported by family members or people getting themselves into care. So it's really that combination of people transported, some of whom are on 5150s, and then people also just being navigated to through family or social connection resources or themselves. As the slide notes, the services that are provided include, kind of point-in-time intervention, assessment, help with medication. That's really critical. A high percentage of folks we see in crisis stabilization units tend to have psychotic spectrum disorders, and medication is incredibly important. But it's far from the only emphasis. And in fact, I would say one of the things that we are most gratified by is the importance of peer support in the work that happens at crisis stabilization units across the county. And then, as I was noting, really critical emphasis on connection to ongoing care. The patterns that we've come to expect with respect to care and emergency departments are you show up, there's some kind of like addressing of the most acute need, and then there is usually not a very effective connection to ongoing care, especially if the primary need is behavioral health care. Crisis stabilization units, kind of just the opposite. The emphasis, as soon as a person is there, is on what we can best do to connect them to the most appropriate ongoing care so that we will see over the long haul the best outcomes. I'm hoping people on the call are able to see the photograph on this slide. It is of the North Coastal CSU in Oceanside. This is a clinical service that is run by Exodus Recovery. I mentioned Luana Murphy, so Luana is the CEO, the very esteemed CEO of Exodus, which runs this clinical service. And I'm hoping if people are able to see that what they can tell right away is that it's beautiful. It is a beautiful space. It is disarmingly comfortable. The phrase that's often used is living room, and there's kind of like a model, the living room model that has sets of recommendations around how to approach this kind of service. Really, what's encouraged here is is a space that clients or patients can to some extent navigate themselves, right? It's not as kind of prescribed a space as a traditional clinic space. And there is kind of everything about the design is meant to be trauma informed, to help people feel more comfortable, to help people feel kind of less escalated in a current moment, and to help people feel valued. in the moments of their experience and care. This is not the kind of space we tend to associate with behavioral health care generally, and in particular behavioral health crisis, right? We tend to think about cinder block. We tend to think about, extreme measures to manage, potential episodes of violence. That is not what this space looks like, and that's not what it feels like. And I would again emphasize that the peer support provision that happens here is a key piece of that, right? This is relational care. It's grounded in relationships, and the space really is conducive to that. And I think even when you're in the exterior of this space, you can sense that it's like lovely, it's friendly, it's welcoming, and that's a really important facet of this. Rachel, anything that you would want to add to my rambling about this, about the nature of these services?
No, I think you covered it.
Okay, great. Can we go to the next slide? Great. So this is very exciting, we think. The CSU that we're establishing in East County will be the first instance, we think, anywhere in the state of California where mental health crisis stabilization unit services are being coordinated directly with and co-located with services for substance use. Services meant explicitly to address episodes of intoxication and substance use disorder and harms related to substance use. And so we are calling this the Recovery Bridge Center. And it's really like what we're proposing is kind of, two sides of a coin. It's kind of fiction to imagine that it ever makes sense to establish a stabilization service that isn't meant to address both mental health and substance use. We see their co-occurrence so frequently in actual presentations, but and I think those of you on the call who've been in this space for a long time would agree, right? The regulations haven't caught up with reality. And that's not unusual in healthcare, but it is certainly true here, right? Like the crisis stabilization units for mental health generally are not spaces that are regulated to address substance use. There isn't that like formal expectation. So we're pairing these two services together. The populations that will be addressed by the two may overlap. They may also be distinct, right? There would be people who would present with intoxication, with substance use disorder, who don't have co-occurring mental illness, but very likely there are opportunities over time to sort of to increase the harmony of these two services and really make them work together more and more optimally. The Recovery Bridge Center is going to be really anchored by what we call a sobering service. This is a very low threshold service. So it's not detox, right? Which is, I think, what most people, when they think about what's drug treatment, what's the front door to drug treatment, it's detox. This is not a detox service. This is a space with a lower clinical threshold. So not gonna, people don't have to make a commitment to sobriety to get help in this space. They instead will be welcomed into this space in moments when they are intoxicated and they need to spend some time sobering up. Transports in this case will be largely through law enforcement. And this service is traditionally framed as a diversion from law enforcement. It's as a standalone, been very effective in other jurisdictions. And importantly, it exists elsewhere in San Diego County. So this isn't the first instance of a sobering service that's being developed. It's the first instance of one in coordination with a crisis stabilization unit. But I think, some people would maybe be concerned, oh dear, the county is establishing a sobering service. That means everyone who's intoxicated is coming to alcohol. That is absolutely not the case. Again, this is all hinged to the principle of regional distribution. So this is a service meant to be available for people from the community where it sits. it's, you know, and it's meant to be one that works in increasing harmony over time with the crisis stabilization unit, and it's meant to be one that also hews to the basic principles of which we started, which is connection to ongoing care. So we're having a sobering service, but we are also exploring the idea of establishing a small substance use disorder treatment component that would enable people who are, you know, initially entering the space for sobering services to be connected potentially to ongoing substance use care, to really sort of have their addictions treated, which is great. That's all I'll say about this for now, for risk of taking all the time. But I want to again invite Rachel to sort of say anything from a public safety perspective about the sobering service and SUD component.
No, you have it covered. You're making it easy for me tonight, Luke.
Oh man,
Man.
that's probably not good. Okay, super. Let's go to the next slide. Great. So this is the site, and I'm not sure if I should just speak to, I can't remember. I'm sorry if I should just speak to this or have Dave Dobson from DGS speak to this as well. I'm happy.
Yeah, Luke, you can speak to this.
Okay, great. So you can see this is the location that we're proposing, which is on Magnolia Avenue in El Cajon. This is county-owned property. It's been the site for, gosh, I don't know how long. My colleagues from the Department of General Services would better know, of the county assessor's office. It's a space that we are not planning to you know, to like renovate. We're not going to renovate the current building, for people who know the particular building, and would probably be thinking at this point, how are you going to turn that into the kind of beautiful place that you showed us from Oceanside? But we're planning rather to tear down the current structure and then to build a new one on this site to house the combination of services that I've just described. You can see on the slide the adjacencies, or proximity of other service providers across the eastern region of our county, including Sharp-Grossmont Hospital and Alvarado Medical Center, and then the service is very close to the El Cajon PD station. That's all I'd say on that slide.
Okay, now we are going to turn it over to Dave Dobson from the Department of General Services to talk about the construction schedule and talk about the physical building itself.
Okay, John, can you please go back to the previous slide?
Yes.
Just want to add a couple of things here. Okay, as Dr. Luke said, this is a piece of county-owned property at 200 South Magnolia Avenue. It's located at the intersection of South Magnolia and West Douglas in the city of El Cajon. The site was chosen because it's close to public transit and freeway intersection that would allow for easy access. And it was also chosen for its proximity to other East region-based behavioral health services. This will facilitate connection to ongoing support and treatment. Next slide. Okay, so I'm trying to run through this for ease of time, to make my time as expeditious as possible. So the creation of the program for this project began a year ago. The county is currently in the process of procuring the services of the building contractor. The contractor will work with the design team to provide constructability reviews and cost estimates throughout the design process. We are currently about to begin the schematic design phase. Construction is currently anticipated to begin spring 2024 and expected to take about 14 months to complete. Next slide, please. Okay, so the East Region Crisis Stabilization Unit, the facility, will be located on roughly 3/4 of an acre of county-owned land. The existing home savings and loan building is expected to be demolished during the second half of this year, with the intention of salvaging as much of the brick as possible and using it in the design of the new building. Next slide. Okay, the new facility will be a 14,000 square foot building located on the western half of the site. Vehicular access will be through the existing alley off Douglas Avenue into the public parking lot where the Home Savings and Loan Building currently stands. The employee parking lot will be located to the south of the new building, creating a buffer between the CSU and the neighboring residents. There's also an existing bus stop located on Douglas Avenue that will remain in place. The public will enter the facility through the front entrance that leads to the lobby. Clients will be evaluated and registered prior to being escorted into the CSU or the RBC. There's also a drop-off lane in front of the building, leading to a secure entrance for the drop-off evaluation area. Next slide. Okay, so the Department of General Services chose the architect firm Platt Whitelaw to design the project, as they have successfully completed the crisis stabilization unit that opened in Oceanside last year. The county wanted to recreate that success for the East Region CSU project. A team of clinicians from the county's Department of Behavioral Health Services met with the architect to create the building program that led to the preliminary design that we are presenting today. Next slide. Okay. So Dr. Luke already discussed the functions of these spaces. So the RBC Recovery Bridge Center is shown in blue. They'll be provided with enough room to accommodate 12 cots for male and 3 cots for female clients. The average length of stay in the RBC is expected to be around 4 hours. In addition, the RBC will have showers for the clients to use to get cleaned up before they leave. The substance use treatment clinic is shown in purple. This will be an outpatient meeting area for individual and group meetings and will only be open 4 hours per day, 20 hours per week. The drop-off evaluation area shown in brown will include several examination rooms. Clients will be then evaluated and be escorted either to the CSU or the RBC from here. So the CSU, which is shown in orange, will be furnished with 16 recliners for the clients to use as to de-stress. The client area is 2,800 square feet of open space with 3-foot high partitions between the recliners to give the clients a sense of privacy. There's an activity room for individual or group activities that contains a live wall, which became a very popular feature in the North Coastal CSU, and the county wants to utilize those in all future CSUs. Even though the CSU will be a locked facility, the average stay in the CSU will be less than 24 hours. The light blue area and yellow areas are staff and building maintenance areas. Okay, John, next slide, please. So sustainability. The sustainability initiatives that we are going to employ on this project are LEED Gold certification, zero net energy, and reduction of embodied carbon. The County of San Diego requires all new buildings to obtain U.S. Green Building Council LEED certification for green buildings. LEED stands for Leadership in Energy and Environmental Design. The Department of General Services goal is to achieve LEED Gold certification for this project. The facility will utilize solar panels to generate its own electricity. Zero net energy means that the building will produce more electricity than it uses. There will be no gas appliances used in this facility. So additionally, the project goal will be to reduce embodied carbon emissions as created by this project. Embodied carbon is greenhouse gas emissions that arise from creating and installing building materials. Reducing embodied carbon can be done by using low carbon steel or concrete, or using wood construction, which we will be using for the East County CSU. We will attempt to reduce embodied carbon to the greatest extent feasible. Okay, next slide. Okay, so these are photos of the exterior of the crisis stabilization unit in Oceanside. This was an existing building with the parking on the ground floor. We renovated the 8,000 square foot space into a CSU. Next slide. So this is the interior of the CSU. We see the recliners with the privacy walls. East County CSU will look very similar to this, only the recliners will be more spread out. Next slide. So on the upper left corner is the live wall in the activity room at the North Coastal CSU. Live plants are used to create a calming atmosphere. And the other slides at the bottom and the right-hand slide are the enclosed patio area that provides natural light and ventilation, and which is enclosed with the opaque patio for privacy. And next slide. And the next slide is the Palomar CSU up in Escondido. John?
Thanks, Dave.
Okay.
Okay, so now we're going to open it up to questions, and we have a panel who'll be available to answer your questions. Dr. Luke Bergman and Rachel Solov, who you've heard from already. Dr. Piedad Garcia, who's the Deputy Director of the County of San Diego Behavioral Health Services. Steve Schmidt, Deputy Director of County of San Diego Department of General Services, along with Dave Dobson, who are heading up the construction of the facility. Luana Murphy, President and CEO of Exodus Recovery, who runs several CSOs. Exodus runs several CSUs around the county. And then Kathy Shoemaker, who's Chief Clinical Officer with Exodus Recovery. And Luana and Kathy can talk about the existing facilities around the county and what the experience has been in the neighborhood, for example. So we can open it up for questions. We have one question already, and the question is, once their 24 hours is over, are the participants kicked out into the neighborhood? And why can't you upgrade the former jail space to use for this service? Terrible thing to put in downtown and residential neighborhood. So Luke and Rachel, I think that you'd probably be well suited to answer this question.
Sure, and I think others can contribute as well. So the first part of the question was, would people who have been cared for in this facility be kicked out into the immediate neighborhood? I think that was kind of the phrasing from the question. I had mentioned before that one of the key aspects of this service is that it is focused on connecting people to ongoing care. It's really meant to, to interrupt the kind of episodic cycles of involvement in crisis care that we see, and that frankly we're kind of almost used to, right? We expect it. And I think that's part of what informs the question, right? Because we're so used to seeing people in medical emergency departments not get connected to ongoing care that we think of any kind of care for behavioral health crisis as one in which people are going to be de-escalated and then sort of dismissed. That is not how this works. People are stabilized, and it's a robust interdisciplinary relational behavioral therapeutic and medication involved clinical process. And then logistically, it's about connecting to ongoing care. With expectation of ongoing care coordination. So, and I would invite Rachel certainly to contribute, and then Luana and Dr. Garcia as well, if that's okay.
So one thing that I would add to that is that, it's not, so under the 5150, they can hold them up to 23 hours and 59 minutes involuntarily. But it's not that when that clock strikes the 24th hour that they just release the person. In fact, if the person is not stable, then there's other legal mechanisms to continue that involuntary hold. So you're not going to have people that are being just released from this facility that are not stabilized. And I think Luana and Piedad or Kathy could probably also speak to what we see in these crisis stabilization centers is they have a very high success rate of stabilizing these individuals in well under 24 hours. And they have a track record. We really looked at these, they're not new, and they're being done in other communities elsewhere in the state. And so we have sort of we have statistics to look at of how they're doing in other communities. And what we have seen is that they do not lead to increases of incidents in the neighborhoods. They do not just release people who are not stable. So I think that's really important. And I know that others can speak to the clinical side of that much better than I can. Regarding the comment about using former jail space, I think you're maybe referring to the jail that is the jail space that's part of the El Cajon courthouse. And I think one thing that's important to keep in mind and distinguish is that these are individuals who for I think on very rare occasions are people that are actually committed a crime. I mean, these are people that have been contacted because they're in crisis, but not necessarily because they committed a crime. So I think that needs to be factored into where they're treated and where they're handled.
That's great, Rachel. I appreciate that. And that's very, very true. It's a clinical service, not a criminal justice service. That's a really important distinction. Piedad, would you want to add to that?
Sure. Good evening. One of the primary goals of crisis stabilization units, as Dr. Bergman mentioned, is to connect clients to services, right? And also to offer care coordination to the most appropriate level of service. If there are clients that need additional time for stabilization, for clinical stabilization, and they are on a 5150, certainly crisis residential treatment facilities around the county are an option to connect the client to, if they're voluntary. If they are not voluntary and still needs the 5150, meet the 5150 criteria for stabilization, they are also attempted to connect to existing behavioral health unit beds around the county. So those are two outcomes in terms of connecting clients that may need either additional 5150 evaluation or voluntary. Luana, do you want to add to that, please?
I'd add just a little something, and that is that we always do, well, almost always do, what we refer to as a warm handoff. And that is if our social service coordinators have connected this client with another service, we actually transport them to that location. We very seldom just, as whoever they ask the question, do we just let them out? Well, they're voluntary. If they've been stabilized, they're voluntary and they can leave. However, 90% of the time, we take them to wherever their destination is.
Great, thank you. We're gonna keep answering questions. I'm just gonna advance the slide because there's a QR code that you can scan that takes you to a one pager on this facility. But I'm just going to leave that up so you have time to scan that if you want. But we're going to continue answering questions. So we have another question that asks, other than 5150 holds, can persons be compelled to be taken to this CSU/RBC?
Go ahead.
Who do you want to answer that?
Sorry, yes. Well, I think Luke.
I was gonna pitch it to Piedad first.
Oh.
Unless, so there are two options, the voluntary option, right? As we mentioned before, walk in into the CSU space or the sobering section or walking for medication management. There is no, to my knowledge, beyond 5150, there's nothing that any rules or regulations from law enforcement that would cause a person to be transported to the CSU unless they're on a 5150.
Mm-hmm.
Okay, thank you. Let's see, other questions from the audience? If you could type them into the comment section. We want to make sure that we answer all your questions. And, oh, sorry, I guess, was I not scroll all the way down? Okay, so here we have another question. Would this site potentially be part of AMR's transfer to alternate destinations to avoid unnecessary use of emergency departments.
What's that?
And
Oh,
yes,
I'm sorry, John, go ahead.
I don't know.
You mean, so you're referring to like additional ambulance transfer, right? Ambulance transfer.
yes. The question is, would this site potentially be part of AMR's transfer to alternate destinations to avoid unnecessary use of emergency departments? I think essentially, how is this going to affect emergency room traffic? I think is effectively the question. And will emergency services be able to take patients here to the CSU?
It is actually a really important question, and we anticipate that this service will be really beneficial to surrounding providers of kind of mainstream healthcare that include emergency departments, and to people who tend to wind up in emergency departments in behavioral health crisis. If you get to a CSU in the midst of behavioral health crisis, you've got greater likelihood of getting connected to the kind of care that's really going to be helpful to you. And so, and that's helpful to emergency departments, in the moment when they would otherwise, sort of have to manage a person in behavioral health crisis, which again, they're not staffed to do, they're not organized infrastructurally to do, but it helps the emergency department generally, because then they can devote resources and space that might otherwise be consumed managing a behavioral health hold to cases that they really are meant to address, which tend to involve acute physical injury or acute illness. And so there's really like an opportunity to benefit like the surrounding healthcare systems generally. That's kind of what we tend to see in areas where we establish CSUs. Now, there are opportunities for emergency services in mainstream healthcare to coordinate care with crisis stabilization units. So there are opportunities for folks to who present in a medical emergency department, but who wouldn't benefit from services there, to be connected to CSU. That absolutely can happen. There may be occasionally cases, and Luana was referencing this, where there is acuity or need for longevity of stabilization care that exceeds the 23-hour and 59-minute limit that's part of the regulations of a CSU. So there may be cases where it would make sense because of medical complexity or higher levels of acuity to transport to an ED. So there's maybe some traffic into EDs, and there may be considerable, I think, shifting of services from EDs to CSUs, which again has lots of benefits. Anything anybody else would want to add to that?
I think the sovereign services, also known as the Recovery Bridge Center, when emergency medical services and alternate destinations is implemented, will be able to transport, for example, to the Recovery Bridge Center.
Yeah. Thank you, Peter.
Okay, great. Sort of a related question is, what role, if any, does the mobile crisis response team have in bringing patients to the CSU?
A really big role, a really big role. As you're probably all aware, we have employed and deployed mobile crisis response teams around the county 24/7. And certainly currently, all the mobile crisis response teams countywide transport clients to the crisis stabilization units that already exist, either on a 5150, or many times the person doesn't have transportation. They could also take voluntary patients to the CSUs that are already being implemented and operated by Telecare and Exodus, the mobile crisis response teams.
Great, thank you, Piedad. Another question. This site can support more development, in my opinion, because it is an urban neighborhood near high-density housing, services, retail, and restaurants. Did the county consider building additional services or even housing opportunities on this parcel? If not, why not? That sounds like maybe DGS and BHS could answer those questions. Would we want to start with?
Go ahead, Dave.
I'll take it from a land use process standpoint. So as was mentioned earlier, the building on the site had been the assessor recorder county clerk building till we built a new one in Santee. And the county's process by code is to look at other county uses for the site first. And then if there's no county use, look at other agencies. And then if there's no other agency use, then to consider housing or alternative uses. So in our process of doing that, the request from BHS to have a CSU in the El Cajon area was what fit the bill at this site.
Great, thank you. Jamie, do you have any questions coming in? No? So we'll stand by for other questions for a couple minutes. So please answer questions. Just want to remind you that we want to make sure that we answer all of your questions. And if something occurs to you at a later time, you can email questions certainly. And I'll advance the slide to include the email address, or you can visit that website. So just really want to emphasize that the county wants to be very transparent and upfront and about the facility and its services and construction schedule. And we're here to answer questions at this time. Here's another question. Will medications for addiction treatment be available through the CSU or RBC? It's really a clinical question. So Piedad or Luke?
Well, so I would say thank you, Marissa, for the question. And you know, better than most folks what the expectation would be with respect to sobering services. Obviously, now we're getting a spate of questions right at the last minute. You know, we would absolutely anticipate connecting people to medication-assisted treatment where that makes sense. We're you know, I think again, not contemplating you know, a formal clinical SUD service that would you know, kind of require massive infrastructure like an MMTP or NTP, I guess we call them here. So that we aren't considering, but an emphasis on medications for addiction treatment that can be provided in the kind of space we're looking at here, we are of course very, very open to. Then there was one last question.
Yeah, we have a couple. What is the scheduled opening date for the facility?
It'd be spring 2025.
Spring 2025. Thank you, Dave. And one more question. What is the children ESU?
Oh, I imagine that's a question regarding the slide that we showed with the distribution of crisis stabilization units across. So that's the ESU stands for Emergency Screening Unit. That is a service that we have had for some time. So it's a extant service in the Hillcrest neighborhood of the city of San Diego, and it's basically shorthand for the current conversation. It's a children and youth version of a CSU. It's meant to provide the kinds of immediate stabilization services in connection to care with a focus on behavioral health for young people.
Great, thank you, Luke. We're at 6:59. Any final questions? We're happy to answer. And just to remind you, you can always email questions and we'll get back to you.
Thanks everybody so much for joining. We really appreciate your engagement. Thank you. And thanks so much to the panelists. We really appreciate your time.
Yes, thank you to the presenters and thank you to the people who attended. And again, please reach out if you have any other questions. visit the website or email us questions. So thank you. And with that, we'll sign off.
Thanks, everyone.
Thank you.
Thank you.